Hi. I want to talk to you today about personality disorders. And I might do this in two parts, only because it gets to be a little long. So, first thing I want to talk to you about is personality. And it's always like, what is a personality? Um, and personalities are patterns or qualities of a behavior that a person has, physical, mental attitudes that a person comes with. And we all have a distinctive personality. I mean, personalities are made up of a lot of things, like some of us are louder, like moi. Some people are more quiet. Some people are more outgoing. Some people are more shy and not so outgoing. Some of us need to come inside and be quiet in order to restore our energy. And some of us need to go out and be with other people to get that same kind of energy. So it's definitely, it's what makes you you and makes your friends who they are and people that you care about who they are as well. So everyone has some distinctive qualities, and I'm sure that you can describe some people that you're close to and what they're like. What's that person like? How are they? What do they like to do? How do they look at things? What do they do for fun? All those kinds of pieces that make people unique. So, personality disorders, then, as the name implies, is a lasting pattern of experiences and behavior. And this is all on your Blackboard slides. That person's personality really deviates from the cultural norms. I mean, they're different. They don't quite fit in, so to speak. Their disorder is pervasive. It influences everything about them, the way they behave, the way they look at life, the way they develop relationships, the way they have friends, the way they do their job. Um, Disorders are inflexible. Um, they're difficult too because, the thought is that people develop a personality, teens to young adult. And it's very, very hard for people who have a personality disorder to recognize and admit that there is something wrong, some reason why they don't fit in. How come I don't have any friends? Why does no one want to be close to me? And for the most part, people with personality disorders don't come into treatment. So in a few minutes, I'll talk about some of the personalities that we do see in mental health care, psychiatric care, people who might be seeing therapists that want some direction. But the key here is that we know that person is outside of the norm and they don't always know. So in other words, the way they behave might be a problem for us and not necessarily for them. So onset, again, adolescence, early adulthood, it's a disorder in that it creates distress, it's impairment of functioning in socially and especially in relationships. So what are some examples of traits that we all can or recognize with each other? Again, I talked about some people are shy, some people are retiring, they're more formal and not so forthcoming. Some people are funny, some people are loud, some people are spontaneous, just like never quite know what the reaction will be, but there is a reaction pretty quickly. Some people are very thoughtful. They just, we think of them as, wow, he is a very kind and thoughtful person. Considerate, maybe great manners, maybe has an ability to put themselves in another person's shoes and gets it, gets what's going on, gets what's happening for that person. Some people are very self-centered. I mean, you know them, you start to talk about something and of course, well, I did that too. And when I did it, it's always like you start up a story and somehow it gets co-opted by them. Now we're talking about you. You asked me. Now we're talking about you. Some people are quite blunt and, we talk about them being outspoken and just say what the reality is and don't soften it. Don't try to put some flowers around it, but just are darn right blunt. And I think I always appreciate people like that, but it takes some getting used to, because I think for many of us, we try to couch what we think and feel into some um, piece where people can identify with it, and we can be explaining things at the same time. But again, some people can be quite blunt. And that doesn't mean that they have a personality disorder. That's just who they are. Yeah, she tells you like it is right away. So clustered personality traits. So here's where we begin to look at personality disorders. Disorders will come with a number of traits that you can recognize. Traits being the way they present themselves and especially the way they behave in relationship, in jobs, on sports teams, as a roommate, as a partner, as a spouse, the way that person does respond to the rest of the world. So the traits can describe a person. They can be healthy traits, that are balanced and that person is enjoyable to be with. They've got a great attitude about life. They work hard. They're able to change. They make mistakes. Of course they do. They can admit to them sometimes. They can be stubborn sometimes. And then there's a cluster of traits that are unhealthy. Healthy clusters, that person can function in society. They get along with others. It's like that kindergarten thing, gets along well with others, can have friendships, can have intimate relationships, can work with their fellow workers. I think too, in terms of intimate relationships, sometimes that's where we see people really struggling, because we are mostly ourselves with people that we're more intimate with. We really share who we are organically, and down to very fine things, the way our bodies move, look, act, the way we behave. And the true test, I think, in terms of growth, personal growth, is being able to be with someone and being more intimate with that person. So unhealthy clusters of a personality. So limited function. That person really has trouble getting along well with others and may be able to for a certain period of time, but maybe not beyond a very brief time in a relationship. That person has trouble maneuvering systems that they're involved in. Again, trouble maintaining relationships, just not quite knowing how to do it, or things aren't going real well, or there's no like conflict resolution or being able to talk to someone and disagree with someone. Trouble in the workplace, trouble in school. And you may know some people that can fit into these categories where, wow, just kind of an odd guy, kind of a, this girl just doesn't seem to fit in or difficult to get along with, or it's really hard to get to know that person. So unhealthy personality clusters. So the characteristics with personality disorders is, first of all, it's lifelong. It all comes together, it firms up early in our life, and it lasts throughout our lives. We don't really change per se in terms of our personality, but we certainly have to look at things that we might be able to change. And again, going to that person who has a disorder, primarily, they don't see a reason to change. It's going to be about you. It's your fault. It's the way you're interpreting. It's the way they're doing things. And it always gets put out on other people. Their symptoms don't bother them, but they do bother other people. Their disordered behaviors are repetitive, maladaptive, and self-defeating. It's almost like, wow, people were just beginning to know her, know him, and she erupted and really angry and stormed off, and I don't even know what happened. And that person can have some kind of repetitive pattern in terms of working with others. People with personality disorders, again, rarely seek help on their own, does not see anything wrong with themselves, tolerates stress poorly, and usually is anxiety-free until confronted with a stressor. So again, their life feels okay to them until there's some kind of conflict or stressor. Now, there's 3 categories of personality disorders. So there's several named personality disorders, but there are 3 types of disorders. Let me just quickly go through this. There's the dramatic and emotional, there's the odd and eccentric, and then there's anxiety, fear-based personality disorders. So let me go back. All right. One of the first categories called dramatic and emotional. These are people who, if you've met them, you were struck by how difficult they may have been. So we're talking about a person with a borderline personality disorder. And in mental health, you'll hear that term used a lot. Unfortunately, sometimes people with that personality disorder are called borderline, which, again, you know how I feel about applying labels to people. So I'm always like, that person has a depression, that person has bipolar illness, that person has a borderline personality disorder. Narcissistic personality disorder is another disorder, and I'm going to go through these in a minute. It's not so common, but it's striking. That person is so self-centered and needs so much to feed their own sense of self-worth and ego, that you're very mindful that the world exists for them. And I think in this day and age, you probably can recognize someone who has that type of personality disorder. Histrionic personality disorder, someone who's pretty, the name implies what's going on, pretty dramatic and noticeable and makes a big deal, and isn't quiet, and you're definitely well aware of that person. And then antisocial personality disorder, which are people who can be very, very difficult. Sometimes antisocial psychopath is put together, and there really is a distinction, but the person with antisocial personality really has no regard for other people. Life is about them, and they'll manipulate and get their needs met at the expense of others. The odd and eccentric personality disorders, there's 3 in there, and I'll go through them in a minute. But one is schizoid, one is schizotypal, and the third is paranoid, which I know you know the meaning of that. Now, sometimes people get confused with schizoid and schizotypal, thinking that it's some derivative of schizophrenia. It's not. It's very separate from that, but it has a familiar sounding name, and the root of the name is similar to schizophrenia. Then there's the anxiety, fear-based personality disorders. There's 4 in that. So obsessive compulsive personality disorder. Now it's separate from obsessive compulsive anxiety disorder, and I'll explain that in a minute. Avoidant personality disorder, absolutely. You can imagine the sphere that they work within is one of avoidance. They're not going to tackle a problem or look for a solution for a problem, but just avoid whatever is happening, any kind of stress or conflict. Dependent personality disorder. Now, you know, you and I know people who seem dependent about certain things. You know, we certainly were that way in our young life when we were children, adolescents, maybe even young adult. We're still kind of dependent on people that care about us, our parents or caretaker. So you know that part, but this person definitely extends that period of time and is remains dependent throughout their life. Passive aggressive personality disorder. People with this disorder are very difficult because they're not always honest about things, but do things in a very passive way, which can be very undermining for anyone and any relationships they may have. It really can easily destroy a relationship. So I'm going to talk about borderline personality disorders because it's one of the most dramatic, and it's one you'll most often hear about. You know, you'll hear someone say, oh, she's borderline, and oh, geez, and, you know, that sort of naming, and very pejorative, really pejorative. Now, people with borderline personality disorders are very challenging. It's very difficult to work with people with this disorder. And I guess when I say that, I'm talking about working with people as an outpatient clinician in mental health. That persons with this disorder are very challenging. So first thing on there, very challenging. Highly unstable. Yep. And some of the features are that person can have suicidal thoughts, can attempt suicide, sometimes die by suicide, maybe accidentally at times. And so, you know, when I would work with persons with this disorder, it was big for them to get to some place of stability because for the most part, their lives were very unstable. History of difficult relationships. And people who have this disorder will talk to you about some of the relationships in their life, and they loved someone and they really loved living with them and they were great. And then this happened and that happened, and I don't know what's wrong with them. They couldn't get along with me. So, you know, the problem always gets put onto that other person. And you would hear them describe some of their relationships. Persons with borderline personality can be very impulsive, and this is where the danger comes in. I worked with a woman actually at the state hospital who finally was able to live in a boarding home or a group home in the Portland area. and would constantly threaten to kill herself, would cut her wrists, and would end up back in the hospital. And then several years later, I heard that she had jumped off the Casco Bay Bridge and died. And I'm quite certain she didn't plan all that out. I'm quite certain it was done very impulsively, and it's quick. Things get done quickly. People with this disorder can be confused about their career goals, their values. There's some literature written that they might struggle even with knowing their sexual orientation. Now, along with that doesn't mean that people who are questioning their orientation, whether bi, lesbian, gay, have a borderline personality. But just like so many things for people with this disorder, they can really be questioning about what's true for them, what rings true for them. Confusion about self, their real identity. If they could get centered and get grounded, how wonderful that could be, that they discover that and believe in that and follow through with that, but really struggle with being self-identified. I put frequently cut or burn, frequently do harm to themselves. Sometimes it's out of anger, sometimes, and I don't mean to say get attention, but might be trying to alert someone of how they're feeling. They can have some strong feelings and be in a lot of pain. This doesn't sound fun, does it, to have a borderline personality disorder. Threaten or attempt suicide. People I would work with on an outpatient basis. Really, the focus for me, and I would talk to them, is for them to stay safe. Like, how can, when you get upset with your girlfriend or your boyfriend or your wife or whoever, you go right to cutting. You go right to jumping in your car and speeding off. And, you got to put some distance in between and not be so impulsive and not do things that are so high risk in terms of harming yourself or harming others. A lot of times, and this is where your empathy will probably come in, is a lot of times people with this disorder have had severe childhood abuse or neglect. There hasn't been a constant object for them, someone that they learn from. The baby looks into the mother's eyes, and the mother is the whole world. And the piece about persons with this kind of personality disorder is that there hasn't been that constant object for them early in their development. And in fact, they might be very, very mistreated and abused by the person that they trust the most, which you can imagine how devastating that can be. About 2% of our general population have borderline personality disorder. So it's not huge. What happens though is it's so dramatic. Their behavior is so dramatic that you absolutely remember them. And as you're working with people with this disorder, they can certainly be overwhelming. So they make a big impression on you. 75% of people with this disorder are women, are female. I think too, someone once said, and don't quote me on this, but sometimes I think it can show up for men in terms of having sociopath borderline personality. All right, so the next one is the narcissistic personality disorder. So it's dramatic. This person has a great deal of self-importance. They crave admiration. They exploit others to look good. They're unrealistic about who they are and their talents and their accomplishments. They have an inflated view of themselves. Get extremely angry if criticized or outshone by someone. You know, the spotlight isn't always on them, and they can rage. Can be professionally successful. So, you know, don't be fooled by that. People can be very professional, have great jobs, great professions, you know, congressman, president, doctor, lawyer, teacher, but can have this disorder. And it's not always easy to figure people out. You know, that's another piece. Not always easy to figure someone out who has a disorder. And maybe that could be a good clue from the beginning, like, wow, something isn't quite right here. This person, narcissistic, rarely has long-lasting intimate relationships. So we know some people, inflated view of themselves, very professional, very well known, and really struggle to maintain an intimate relationship. People really move away from them and or don't want to have anything else to do with them. Thankfully, there are fewer than 1% in our population who have a narcissistic personality disorder. And 75% of the people are male. So that's interesting. Now, histrionic is what it says. Overly emotional and dramatic. I mean, I'm not just talking about someone who loves to act or, you know, they sing or whatever, but consistently overly dramatic. Like, oh my God, here we go. We're going to hear about this and then that happened, and then this happened. And, you know, and there's always that story that goes along with it. People with this personality are very hungry for attention. Makes sense, right? They're telling you something, it's very emotional, it's very dramatic. Persons can be flirtatious, they can be seductive, drawing attention to themselves. You know, they go to great lengths to shine the spotlight on them in terms of drama. Emotionally, even though there's a lot going on there, they can be quite shallow, not have the depth that you and I work hard to engender and hopefully grow with. So can be quite shallow. I don't know why, but she does not get it. I keep explaining why. And they're just like, I don't know. Live often in a romantic fantasy world. So things aren't what that person sees or relates to you. Easily bored with routine. Well, yeah. I mean, if that person is dramatic, histrionic, overly emotional, then the mundane, the everyday life could be very boring. Now, 2 to 3% of the population have this disorder, and women are seen more in clinical settings. So what that means is that we're not quite sure if it affects women more than men, but oftentimes women are who we work with, who may get depressed or be in difficult situations. And so they can show up, in other words, more often than men. Now, then there's the antisocial personality disorder. We call people with this a sociopath. Person is a sociopath. Now, I don't know why I'm being okay with that in terms of I never use labels, but I think culturally, we've learned to alert one another to that. You know, we're aware that people will harm people and animals and property and have no conscience about that. Don't feel guilt, don't feel shame. I mean, the shame might come in that they've been found out, but just really don't have that super ego. Remember that Freud talked about. Somehow that doesn't get developed um, for persons with a sociopathic or psychopathic personality. That person uses lying, manipulation, selfish disregard for the rights of others. Doesn't. Um, can be very impulsive. Precursor behaviors, in other words, things that you might become aware of early in their life, are hurting, killing animals, fire setting. I think I mentioned that with kiddos that have been abused and badly mistreated, often will hurt or kill animals, will set fires, will harm other people. If they've been sexually abused, will be perpetrators. Often chemically dependent, which you can imagine makes it even worse in terms of their behavior. Sexually promiscuous. 3% of males in the population and 1% are females in the population. So women don't get away with this. You know, we have some pretty difficult women who can be sociopaths or psychopaths. All right, so then there's the next category of schizoid personality disorder. Now some of the traits are odd and eccentric. That's kind of what we characterize the traits as. So this can be someone who's a loner, doesn't have close family, doesn't have social contacts really, can be very aloof, prefers to be alone, never can draw them out. Come on, come with us, we're going, come with us. No. They can seem cold, rarely display strong emotions. So it's always like, boy, I don't know. We've tried to reach out to that person and we don't seem to get anywhere. And I don't know. And, eventually we give up, right? So it all comes true that that person is alone because we're done. It's like we've made so many overtures and tried so hard. They can be quite successful in occupations, but a lot of the occupations don't require personal interaction. So this might be someone who's very quiet and diligent, does a great job, but it's a job where there's not much social interaction at all. And I'm sure you could think about some of those occupations that really don't require working in a team or working with other people. 2% of the population are thought to have a schizoid personality disorder, and slightly more in men than women. Now, then there's a schizotypal personality disorder, is also part of the odd and eccentric. That person's considered odd or eccentric. They pay little attention to their clothing. They have a peculiar speech, some odd mannerisms. Don't quite, boy, they're different. If people watch, and I love doing that. You sit in the park and it's a busy place and you watch people go by, and, some people you kind of get like, oh yeah, that's how they can be. And then there's always someone that's like, wow, I don't quite get it. I don't quite get it. That's always a good clue. Don't quite get it. They can be socially isolated, uncomfortable at social gatherings. Often oddities of thought. They can have magical beliefs. For example, peculiar ideas. It's like, wow, how did you put that together? Wonder why you think about that. You know, in the slides I've put telepathy or UFOs, and I don't want to just lump everyone who has some extra sense into this category, because I do believe some people have extra senses that are truly there for them. They're open to them. But just someone who might always be kind of concerned with the magical parts of life. Or 3% of the population, slightly common in men. And again, not to be confused with schizophrenia. So it's not schizophrenia. It's not an illness per se. Again, it's that personality who makes that person unique in the world. And it's a disorder of personality. Paranoid personality disorder. Now, you know paranoid, and it's a terrible place to live in the world. So this person is always suspicious, thinks others are always out to harm them, to cheat them, you know, and we see people like this. We see them in the news. They're always angry. Someone's, you know, done some injustice toward them, or they're trying to get them, or they're trying to rip them off, or, you know, they're trying to bring harm to them. So it's not like a psychotic thought, like a paranoid delusion. It's this sense of others are out to get me. That's just it. I'm never getting ahead because someone's out there ready to blah, blah, blah. And you know those people. Sometimes they can be the people that write into letters to the editor frequently, complaining about systems and what happened with this and what happened with that, and this what happened with them with that, and this what happened. And I mean, we all have legitimate things that we can complain about and want to fix, and things need to be fixed. But this person really is out to be suspicious. That's their primary mode. I have in here, they can be litigious, lawsuits, you know, quick to, oh, I'll sue them. I will, you know, and it's like, wow, what a world you live in. How difficult that must be. You know, it's like people who live with incredible anger, and how wearing and upsetting that can be. People with this personality can develop psychotic symptoms under severe stress. And, you know, that can be the same for any of us. Our minds can absolutely play tricks on us, so to speak. And, you know, we've talked about depression and anxiety and how the brain gets exhausted and can absolutely start to be psychotic. So under severe stress, I mean, that would go with any of these situations. 0.5 to 2.5 people in the population are thought to have paranoid personality disorders. All right, then there's obsessive compulsive personality disorder, which is a disorder, anxiety and fear-based. So this is the third category. An obsessive compulsive is similar to anxiety, although it's not called anxiety per se, but there's a lot of the behaviors that would mimic someone who has obsessive compulsive anxiety. So this person is very preoccupied with keeping order, attaining perfection, maintaining mental interpersonal control. So people in this category can be very controlling. They're someone who isn't going to budge. They're going to do it this way. That's the way to do it. I have to do it that way. I have to do this. Just very rigid. Um, People with this disorder will spend a great deal of time adhering to their plans, adhering to a schedule, adhering to rules, like rules are not meant to be bent or broken. They are what they are. We need to go according to the rules, and they can be pretty rigid. Won't deviate. People with this personality disorder are unable to relax. And a lot of times, persons we call workaholics might be in this category. It never ends. Things are never good enough. It's never right. It's never following all the prescribed steps. A lot of times they'll have problems with employment and intimate relationships. Absolutely. Insist on doing everything their way. I mean, people that are so rigid aren't going to have the kinds of relationships that we look for, where there's give and take, and understanding, and don't always go by the rules. 1% of the population, in male to female ratio, it's about 2 to 1. 2 men to every one woman, or 2 males to every 1 female. Obsessive compulsive personality disorder. Avoidant, just what it says. The big thing here is this person fears rejection, shies away from situations, occupations that might expose their inadequacy, and they see themselves having great inadequacies. So they'll reject opportunities, close relationships, for fear of being criticized and or humiliated. I mean, that would be just devastating for them. Sometimes they're diagnosed with dependent personality disorder, and can fit criteria for social phobia. Remember, the people that won't come out, don't want to go to parties, don't want to be with others. We think of them having social anxiety, social phobia. But sometimes it's more pervasive than that. It really affects their whole personality. So between 0.5 and 1% of the population have an avoidant personality disorder. Dependent personality disorder, what it says. And again, it's in that category of anxiety and fear-based. So people really are struggling, really don't feel good about the world that they're in. Persons with this dependent personality are very afraid to be on their own. So that you can imagine that you might be in a relationship with someone who has this almost personality disorder, and or maybe you've known family members, parents, grandparents, where there is just such fear about being left alone or not having someone to depend on. That person can be submissive, compliant, yeah, because they don't want to be alone. They can avoid displeasing because, again, they don't want that person, whoever they are, to leave them or to be left, or to leave that person. They're afraid to question authority because they don't want to be left out. They're going to go along with. So you can imagine they can be pretty compliant. Oh yeah, no, no, yeah, oh gee, yeah. They'll ask others for guidance and direction. They don't take the lead. And it's like, boy, I'm getting really tired of working with this lady. I mean, she's always asking me, what do I think? And why don't you go ahead and do that? And I'm always aware that, wow, I'm ending up doing all the work here. It's diagnosed more often in women. And what I have here is that it probably reflects the social pressure on women to conform, to gender stereotyping. But you know what? You got to really look at that, because I think more and more women are very confident about their ability to be on their own and say who they really are. So, you know, you really have to look at that. Like culturally, yeah, maybe women were more dependent for a long time, but we've certainly grown out of that role. And then you can imagine how narcissistic persons with a narcissistic personality disorder and a dependent personality disorder are very attracted to one another, because the narcissistic person is very happy to say whatever's going on and be right and be in the spotlight, and the dependent person really wants to be taken care of, is compliant, won't step out of turn, won't object. And so you can see how those two can easily go together. Let me just take a little break here. So I'm trying to do what you did the other day, and somehow I'm not being very successful with this. And actually, I've got trees showing up in my teeth. So I think I'll get out of this. If I go over here, then it's going to be the sky showing up in my teeth. So let me pause again, and I'll come back to you in a minute. All right, so a little bit of humor there. I tried to join a faculty meeting today with Botanical Gardens of Boothbay in the background. It didn't work real well. So I don't know how the heck you guys did that the other day, but it was fun, especially the one that was in hell. I thought that was great. Anyway, so back to this, and I realized that I'm probably going to get this whole thing done in this video. And then I only have one more talk to record for you, and that'll be on eating disorders, and just a brief discussion of somatoform disorders. And that'll take us right up to the end. So I want to talk to you about the treatment of persons with a borderline personality disorder. Now, when I first began, I said, you know, people resist coming for treatment who have personality disorders, but this is an exception. People with borderline personality disorders, by the very nature of who they are, can be impulsive and can really harm themselves. So a lot of times we'll see people come into the hospital who have a borderline personality disorder. And many times, most of the time, it's because they are highly suicidal, have a plan, have an urge, they're impulsive, so you don't always trust that they're going to stay safe if you've assessed them. And so a lot of times will be admitted to the hospital. Then there are outright times when persons with this disorder will do great harm to themselves. I'm not sure I told you about a client I have, and excuse me if I have, but I worked with this woman in her early 40s who had a borderline personality disorder, and also abused substances. I mean, you know, persons with this disorder absolutely will use substance at times in their life. But she went to the Great Lost Bear, got tanked, and walked out and laid down on Forest Avenue, and was taken to the hospital. It's a wonder she wasn't killed. I don't know why she wasn't. And when I saw her following that hospitalization in outpatient, I'm like, what were you doing? You know, it's always like that. And they can get really PO'd at me and get up and leave. And it's like, you know, sometimes you just have to say things because you've been working with someone long enough. And she denied that she wanted to kill herself. And I'm like, oh my God, you know, that seems like a good way to do it. So anyway, a lot of times people end up in the hospital because of that. They're very challenging. Persons with borderline personality disorders are very challenging. They're not easy to work with. It's very easy to not care about them because of their behaviors. And so I think that's when you might hear a lot of pejorative pieces and disrespect toward persons with any personality disorder, but in particular with someone who really is unsafe and always kind of challenging systems, and you can't trust them a lot of times in terms of safety. Here's an important theme to remember, and it really comes down to the very organic piece of someone having a borderline personality disorder. It's, I hate you, don't leave me. So what a contradiction, right? I hate you, don't leave me. And that's kind of like how you have to think about that person when you're working with them, that this is such a struggle for them in terms of having real strong feelings, really hating someone, wanting to push that person away, and then just as quickly pull them back in. So we sometimes say, push me, pull you, push me, pull you. You know, I know that was a character in Dr. Dolittle, and I don't mean to make fun of that, but that's really the dance that persons with borderline personality disorder do with you when you are working with them for some period of time. So everything they could do, you look like shit, Jeannie, you look like you don't care about me, I can't believe you're talking about this again, I'm going to get up and leave. And then, you know, next appointment, there they are, or, you know, they call me and whatever. So you get to know that. You get to know that, oh, okay, this is what's happening right now. And with that too, you know, I would back up and like, let's back up a minute. What just happened that you're so upset with me? What did I do? You know, well, you look like you don't care. And I'm like, well, what does that look like? Because I'm not quite sure that that's what was going on in my head, you know, so it's tricky. That person desperately wants to connect, but again, pushes away by their words and behavior. They can really get you. They can really make things uncomfortable for you. Push and pull, black and white thinking a lot of times, like, well, what would happen if, and they're like, no, that's not it. That's not right. And all or nothing approaches in a relationship. And you can imagine that does not work well in any kind of relationship, all or nothing. I mean, that just isn't the way we socialize or are intimate with one another. So very primitive defenses, Freud defenses: denial, projection, and splitting. Splitting's huge. Ineffective coping skills when stressed. And treatment then begins looking at skills building, putting those skills into place. And DBT is a big one for persons with borderline personality disorders. Now, dialectical behavioral therapy. So DBT, and I know some of you have already looked at that and heard about that, and we talked about it very briefly, but it really is almost like taking an adult ed course. it goes on for several months, and it's practicing emotional regulation. So, and just to kind of put it briefly, it's like, I'm really upset and I want to go smack someone. So, what DBT works at is, what were those feelings? I was really upset. All right. And you quickly wanted to smack someone. So, you quickly did the behavior or the reaction. What DBT tries to do is get you to be more mindful. Okay, you're really upset. What are you upset about? How can you put some space in there? And then what do you think you can do rather than acting out on your feelings? We can all use DBT, believe me, because it does look at, all right, I'm really upset. I shouldn't start yelling now. I should say, I'm really upset about this. And then create some time before we have a response. So DBTs are great. It's a great way to build skills and to be in the moment, stay in the moment. For a lot of people who have been mistreated, you know, they can easily go somewhere. Remember, we talked about that disassociation. And also they can react in a very quick and sometimes very hurtful, violent way. So DBT is one important set of skills that we have persons with borderline personality disorder do. And sometimes it would be started in the hospital and then continue on an outpatient basis. And I'm not sure if it's done in the hospital now because hospitalizations are so quick now. There's just not a lot of time given to building skills in the hospital. So a lot of times this kind of work is in outpatient. And getting somebody to maintain attendance at DBT, that could be the work that I would do for a year, you know, just trying to get them to go to their group and be part of this. So the next slide, it's slide 23, talks about the theory of borderline personality disorder. And it goes back to Mailer, Margaret Mailer, who, remember we talked about separation individuation theory, and that constant object, that person they can trust, that person that's there. And so the thought here again is that early in development, the person with this disorder didn't have a constant object. Just like the toddler, and you probably remember I talked about, they run away from mom and they're all giggly and they look back to make sure mom is still there, or whoever the primary caregiver is. It could be dad or another person that is the primary care person. And that helps us going through that developmental stage, helps us to feel secure. You know, if your boyfriend, girlfriend, husband, wife, lover, whoever is away for a period of time, it's like still feel connected, still feel good about the relationship. You're not constantly calling them like, where are you? Why didn't you call? You didn't call me last night. I asked you to. You didn't call me this morning. And, you know, someone who really has to hear from you pretty regularly or a lot, they're really struggling with being able to let you go, or the person that's important to them let go. Sometimes parents can be like that, really don't want their kid to separate, you know, just really struggling with that separation, individuation. And some kids being able to separate from parent. Some kids will talk about having a very close relationship with mother or father and really not doing well outside of that relationship. Now, that doesn't mean that that person has a borderline personality disorder, but Mayer really felt that part of the development of that disorder came from a very organic kind of seed place of that constant object. And without having that in one's life, there definitely was the possibility of having altered behaviors and characteristics. Sometimes I would do work with that with my clients with borderline personality disorder. I might be going on vacation and they'd be furious. I'm telling you, they can have a strong reaction. And sometimes I would give them a smooth stone, or I bought some little glass objects that were like seashells. They were smooth and couldn't be used to harm anyone or themselves. And I give that to them and tell them, hold on to this. It's from me, and hold on to this. So there's a part of me that can go with you, and that can help comfort you and know that I still exist. People will do that wearing each other's clothing, if, like favorite sweatshirt or college t-shirt, and your boyfriend or girlfriend wears it, or you have something of theirs and you bring it with you. Kids will do that a lot, going to camp. Bunny, teddy bear. These are constant objects for kids as they're growing up. Someone to hold on to, and that's their bunny. That's their teddy. That's their blanket. We all have favorite things that help us feel more grounded, but for persons with an interruption of that normal development, objects can be really important to them. So I tried to get people to use things in that way rather than create crisis in their life. So with borderline personality disorder, so many co-occurring diagnoses, just similar to what we've talked about all semester. Anxiety, substance abuse, depression, mood changes, unresolved grief, PTSD. I mentioned before that persons with borderline personality disorders, many of them have been very badly treated in their childhood. Dissociative disorders, going along with that. Remember, we talked about that, where there's a level of consciousness and that person detaches from what's going on in the moment. Suicidal gesturing, you bet. Suicide completion, yes. Sometimes it's accidental. That person is just gone too far with the plan, with the means, and they end up dead. Legal problems, you bet. Impulsivity, emotional stress intolerance, threatening, stalking, dysfunctional relationships. It's very hard to be in a relationship with someone who is constantly pushing you away and pulling you back, pushing you away and pulling you back. And I hate you, but don't leave me. It's like you'd go crazy in that kind of relationship. Maybe some of you have experienced that with some people that you've known, but it's not a comfortable, loving place to be in. It creates tons of conflict. It's not comfortable. Oftentimes I don't talk about being happy, but being content, and how important it is to be content, especially in relationship. It's not all bells and whistles and exciting and whoop-de-doo, but to think that you can be content in a relationship and be comfortable with someone. So persons with this disorder really, really will not achieve that. Sometimes two people, both with borderline personality disorders, try to get together, and it's not good. So assessment tools, to measure their symptoms, you know, again, just like depression, we use different questionnaires. There's personality testings. MMPI is a famous one. And for those of you who remember taking your psych course or any other psychology courses, you remember that test. Face-to-face interview, history of suicidal and homicidal behavior. I've never really worked with anyone with this disorder who's been homicidal. I'm, very aware that those persons can really hate someone and always be very hateful toward that person, but I haven't really known anyone to be homicidal, wanting to go and kill them. I mean, they would have strong words, and I'd be like, are you thinking of, no, of course not. History of physical, sexual, emotional abuse, absolutely. Mental status exam, of course, just like for any other person that we would admit to the hospital or to outpatient. Symptoms, they can tell you. In some of their more honest moments, they feel empty. Extreme mood shifts within minutes, hours, days. Inclination to engage in risky behavior. My client laying down on Forest Avenue, it was evening too. Intense feelings of abandonment. Wow. I mean, you don't even know if you're in a relationship with someone with this disorder that you've done anything out of the ordinary. Again, you know, it'd be like me trying to take vacation and how dare you, and can I call you, and da-da-da, and when are you going to be, and it's like, no, you can't call me. I mean, that's a piece that we'll talk about in a minute, that, whoa, you have to really set down strong limits. Can feel paranoid. Absolutely. Can feel paranoid. Can idealize others. Will quickly meet up with someone and become their girlfriend or boyfriend or whatever. And it's sort of like, wow, you met that person and you're going to move in with them next week? You know, it'd be like that. Intense feelings, over attachment, and they idealize that person. So whenever that person is human or might be irritated or angry, or I want to go somewhere myself, then you know that you've crumbled their idealization of you. So they can be really angry. Angry, sarcastic, bitter. They can use self-mutilation, harm to self, suicidal behavior, gestures, threats when feeling disappointed, rejected, absolutely. They are so wounded. You know, we talk about people who are so wounded and how difficult it can be to have relationship with someone so wounded. Sudden shifts in self-evaluation, changing goals, values, careers, extreme mood shifts again. I said this already, within hours and days. Some real smart people out there who struggle with this personality disorder, who've built businesses, who've done a lot of hard work and created networks of people to work with, and who can just quickly explode and burn the whole thing down. Yeah, very destructive. So multiple diagnoses you can imagine, all kinds: self-esteem, ineffective coping, around mood, around self-image, any number of things around safety. You know, you would clearly recognize all the problems that that person comes with, and they would keep showing them to you. You know, you might admit someone and they're pleasant, they just, oh, thank you, Jeannie, it was so great, I really appreciate it. The next day it's like, I can't believe that you know, and it's like, what happened? You know, just needs and problems constantly changing. So safety, especially if they're in the hospital, and even on an outpatient basis, making sure that they come in and they're okay to be there. They're not going to create some chaos or hostile environment. You work hard to build trust with them, and boy, it's ongoing. It's always. Why'd you say that to me? Well, I was just trying to ask you what you were going to do this weekend. I know you can't go away with your friend, but what is it you're going to do this weekend? You know. And again, working with people for a long period of time can help. Hospitalized secondary to suicidal ideation, plan, intent, or homicidal ideation. It didn't always trust someone with this disorder that they could stay safe. And I might even say to them, you know, last time I asked you about that, you assured me that you would be safe, but within a couple hours, you took all your pills. So I don't know how I can trust that you will keep yourself safe. Safety of others, their behavior affects the milieu. You know, I've talked about that before, but having someone on the unit who has a borderline personality disorder can really change the whole flavor, makeup of the unit. And for those of you that were able to do clinical in the acute care settings, you know, I'm sure you were aware how people could change the whole makeup of the unit. And as a matter of fact, when I was practicing in the hospital, we were careful not to have too many people on the same unit who had difficult personality disorders. So that would go into some of our decision making about what unit that person may go to. Limit setting, so important and so hard. So plan of care. Everyone, and this is on the next, it's on slide 32. So team cohesiveness. Everyone needs to know the plan of care and follow the treatment plan, from the housekeeper on the unit to the physician, nurse practitioner, the nurses, mental health workers, social workers, anyone, OT, PT, voc rehab, anyone involved in treatment in that, on that unit, has to have the treatment plan in their heads and has to follow it, because this person will do what we call splitting with you. So splitting goes like this. So I go in and I say, Barbara, get up, it's time you got ready, you have group, you know, and you need to come to breakfast and go to group at 10. Well, the nurse over the weekend didn't make me do that. Why are you making me do that? What? Boy, you're mean. So can easily go there. Another example, probably more familiar in your own life, is, you know, you got your mom and your dad and you're little and you want to go play with your friend up the street. And it's like, can I go to Sally's house? And mom says, no, you haven't done your chores. You need to make your bed and you need to help us with the dishes. And then you can ask me again. And so then I go to dad and say, can I go to Sally's house? And he goes, sure, that sounds nice. And it's like, oh, so it's a way of manipulating. It's manipulation. Even when we're little, you know, we're kind of figuring out, how can you get somebody to say you can go? And of course, then what happens is your mom and your dad are furious with each other because the mother set the limits. The dad says she can go. And mother's mad at dad. Dad thinks mother is being too strict. And so the kid, steps out and everybody's like doing this. So you got to be really careful. You got to be really careful. If you're working with someone and they say something to you about someone else, please go and find out what the reality is. And sometimes, I would just go into the nurse that was on weekend and say, do you know what she said about you when I went in to see her Monday? And that person might say, I did not say that, Jeannie. Excuse me. That's not what I said at all. So, you got to be careful because you don't want to be manipulated, and you don't want to split with your treatment team. So everybody needs to discuss the limits and frequent meetings about this person, continuing treatment plans, getting people together. Like, we have a new issue, we've got to talk. And then a lot of times involving the family, significant other for discharge and follow-up. Now, not everyone has family. I mean, just like a lot of the other illnesses and disorders we've talked about, people can really burn out their families, and they may not have friends left. They might have really alienated so many people. So almost done here. All right, intervention, safety, 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 physical, psychological, team approach. What we would do is we would appoint one nurse that would work with that person for maybe the day shift, and then evening we'd ask a nurse to continually work with that person. Now, that being said, people can get really burned out taking care of people with this personality disorder. So you have to keep talking to one another and strategizing. Clear guidelines of expectations from that client. And again, limit setting. I mean, you can imagine that some people with this disorder could create chaos on the unit by splitting. Like, did you hear what that nurse said? Has she ever said that to you? Or don't you think the night nurse is, I mean, they can stir everyone up. And that's why most of the time we wouldn't have more than two, maybe not even that, on a particular unit. Like Spring Harbor, I worked at St. Mary's for a number of years, and we wouldn't have too many personality disorders in that same unit. All right, medications. There's really no FDA-approved medications to treat borderline personality disorder. However, you are going to be treating the co-occurring illnesses, depression, SSRIs, maybe a mood stabilizer, anxiety, PTSD, maybe short-term benzodiazepines, long-term SSRIs for anxiety. And I think I might have mentioned gabapentin also for anxiety. Recently, I was made aware that people can actually become more addicted to gabapentin. It's never been my clinical experience, but probably to be very mindful of that. All right, and then the next slide I have talks about Marsha Linehan's DBT therapy and some very specifically. So take a look at that. I'll probably ask you something about that on the case studies. So evaluation, stay safe and doesn't hurt anyone. Works with the nurse, the therapist, advanced practice nurse, counselor, inpatient or outpatient. and able to change some behaviors. People can change. It takes time. And it's over and over and over again, challenging that person in the way they're thinking and the way they react to things, because they go so quickly. And they really do suffer from anxiety and distress, and their pain of abandonment is huge. It's huge. I mean, you know, I'm sure all of you have had a breakup with a girlfriend, a boyfriend, someone in your life, and how painful that can be. And for a person with borderline personality disorder, it's acute pain. That's what they feel. So if you need to develop some empathy towards them, keep that in mind. All right, and then there's a YouTube video at the end, what it's like to live with borderline personality disorder. I'll have you watch that as part of the last case study test that we do together. So, all right, so thank you for listening to me. I really appreciate you watching and listening to this. We're getting to the end. I hope you're learning and you're able to synthesize some of this information, and take it easy. The end is coming. A good ending is coming. All right, bye. Blessings.